Okay, thank you very much. And also, I thank you very much for inviting me for this conference. My title is Effect of Co-infection of Parasites on Severity of COVID-19. Actually, this paper got accepted last week. I'm having problem with my slides. Huh? Okay, sorry, I'm having some technical problems. Okay, sorry. So this will be my presentation, okay? As I mentioned it, our paper just got published last week at A Clinical Medicine, published by The Lancet. And this will be the outline of my presentation. Can you hear me? Can you hear me, please? Can you hear me?
Yes. Yes.
Okay, so just to introduce you to Ethiopia. Ethiopia is located in the east of Africa. Okay, here we are, very few thousand of miles from Thailand, a very ancient country, which is the origin of both Christianity and also the origin of Muslim. In the continent, we have, as I mentioned, in Ethiopia, we think it is the origin of mankind. You could see this is Lucy, which is 3.3 million years, the first humankind, humanoid skeleton discovered in Ethiopia. We have very ancient obelisks, 3,000 years old, very beautiful churches, even Hawk, from the rock hewn churches as old as 900 years old. I visited Thailand a few years back. I also love Thailand, is a very beautiful country. So the subject that I'm going to talk about today is related to our Profile COV project. Our Profile COV project is funded by EDCTP, the European Union Developing Countries Clinical Trial Partnership, which is funded by the European Union. And this is a collaboration between our university with some local public health institutions within Ethiopia, as well as with European partners, namely the Amsterdam University in the Netherlands, the Academic Medical Center, Uplange Institute, Amsterdam Institute for Global Health and Development, all in Amsterdam, the Netherlands, as well as with the Liverpool School of Tropical Medicine in UK. Just to give you background, you are already aware now we have reached close to 200 million cases of COVID-19 at global level. If you just consider Ethiopia alone, so far close to 280,000 cases have been reported, with only a little bit above 4,000 cases died. We have suffered two waves of the COVID waves, as you can see in the picture. But now we are afraid with the advent of the Delta variant that the cases is going to increase, and we might face with the third phase. As you see, the number of testing in African countries is very low. So we are a population of 110 million, but we have very few cases, okay? Less than 300,000 cases. And we believe we're testing very little, okay? Because if you do community surveillance, our community surveillance shows data as high as 70% in the capital city. One of the things that my group is interested is COVID-19 different in Africa in terms of clinical presentation as well as in terms of mortality and other things. Early data from China after the advent of the pandemic last year shows that the majority of people with COVID-19 present with asymptomatic or mild clinical presentation to the moderate. This is in almost 80% of the cases, okay? Those with severe clinical presentation or those admitted to ICU at a critical condition comprise about 15 up to 5% respectively. This is in China, and this has been confirmed in the northern European countries as well as in the US. Up to 25% of the cases require hospital admission, oxygen supplement, as well as mechanical ventilation. But if you see the case in African setup, we did report in International Journal of Infectious Disease about the general picture of COVID-19, for example, how it appears in our setup. You could see the publication in the lower panel of the slide. And in this series of more than 2,600 patients we investigated, the clinical presentation in the most of the cases is asymptomatic or mild for more than 95% of the cases. Unlike that has been seen in China, in Europe, or in the US, whereby severe COVID-19 presents in more than 20% of the cases as severe or critical, in our setup is less than 5%. So you could see there is a difference in the clinical presentation in Africa. And sorry, this is the rate in the community. And we have seen a very low mortality in Africa for some reasons which we do not know up until now, except in the northern part of Africa and also South Africa, where mortality is high. But in the rest of the countries, it is low. And this is supported by data like this one that has been published recently in Clinical Infectious Disease, showing low mortality rate despite very high prevalence or incidence of the disease in the African setting. So there is some thing that is protecting us from severe disease as well as from the mortality. So these are some of the things that are associated with lower severity or mortality in the African setup. But our interest is in this one, okay? Several ecological studies have shown that several factors are associated with lower severity, mortality in sub-Saharan Africa. Two important factors are the ones in blue here: population age structure. Relatively very younger age of people infected with the virus in our setup on the average is below 40 years, okay? And also previous exposure to endemic infections are important factors that impact on disease, on mortality as well as disease severity. And this is what we try to address. So far, evidence suggests that from ecological studies, just associations, epidemiological studies showing that, for example, schistosoma infection in Africa is higher, as you see it here, but lower mortality or severity with COVID-19. Similarly, with other infectious diseases, ascaris, hookworm, malaria, trichuris have shown the same thing. But population density, as well as residence, whether urban, rural, and age, are also important contributing factors. When I finished my PhD at Karolinska Institute in the year 2000 in immunology of parasitic infection, I did my PhD study on Leishmania HIV co-infection. When I came back to Ethiopia, for the last 20 years or so, we have been interested on the immunological background of Africans, apparently healthy Africans, where they show a lot of chronic immune activation. Okay, we did this when I was the lab director of the Ethio-Netherlands AIDS Research Project, which was at the Ethiopian Health Nutrition Research Institute, which is now the Ethiopian Public Health Institute, which is the national reference laboratory for Ethiopia. Okay, we were conducting for 10 years, 20 from 2000 up to 2010. We were engaged in a prospective cohort of the Ethio-Netherlands AIDS Research Project in collaboration with institutions in the Netherlands, including the Academic Medical Center, University of Amsterdam, the Public Health City Municipality of Amsterdam, Leiden University, and also the CLB. And our project emanates from an observation done by my collaborators from Israel, whereby they showed a lot of immune dysregulation as well as immune activation among the Ethiopian immigrants going to Israel. Okay, it was kind of interesting that the Ethiopian migrants to Israel, the Ethiopian Jewish migrating to Israel, exhibited cellular as well as soluble markers of immune activation in their system compared to those non-Israelis or to Ethiopian Israelis residing there for many years. And these are some of the publications showing immune activation status among the Ethiopian migrants, recent Ethiopian migrants, compared to the white Israelis and also the Ethiopian Israelis that have been living in Israel for more than 5 years. There were some stigmata of immune activation in their system, okay? And this has been ascribed to helminths, not only in among Ethiopians, but also the Italian group in Uganda also described a similar situation of immune activation stats among Africans. And we confirmed again this at INARP, at the Ethio-Netherlands AIDS Research Project, where we compared Ethiopian subjects to people living in Netherlands, to Dutch. Compared to Dutch, cellular immune activation markers among Ethiopians was remarkably and significantly higher, including reduced naive cells of CD4, CD8 cells, but very high level of CD4 and CD8 cells of memory immunophenotype, okay? And we have also confirmed the situation not in one site, but in several sites in Ethiopia, whereby we show a lot of immune activation, cellular immune activation within the CD4 and CD8 immune phenotype cells in different sites compared to the Dutch, okay? So similar studies again, but different biomarkers, and also including among patients with latent tuberculosis, with subclinical tuberculosis, with or without HIV, a lot of immune activation biomarkers. Very interestingly, we investigated whether this immune activation is something that is born with us, that is genetic, or whether that is acquired something during life. So what we did was, we did a comparative study in infants who were born, then in young age group from 5 to 16, okay, and also in adults, because all the previous evidence showed that immune activation was in adults, including very low number of CD4 cell count, okay? Our average CD4 cell count on average is 700, while that of the Dutch among healthy HIV negative Dutch population, as you are already aware, is above 1,000. So we have low CD4 cell count in adults, around 700 on average, with a highly activated immune activation background. But when we checked this at birth, there is practically no immune activation. But as you see from my slide here in the upper panel, with increasing age, the immune activation markers also increase, suggesting that this immune activation is something that is acquired when we grow, and it is a phenomenon that is not born with us. And another interesting evidence is that this is a study we did with my Israeli collaborators. You could see a lot of, this is a baseline, and the second panel of slide is following deworming after treatment of the worms after many 6 months on average. You could see we have a lot of, no, sorry, this is immune activation markers, and these are the parasites. You see we have a lot of helminths, ascaris, hookworm, schisto, Hymenolopus, and trichuris, very high prevalence, okay, at baseline. After, and this is associated with immune activation markers, okay, eosinophilia, IgE, IL-4, IL-10, and so on, interferon gamma. But after deworming, the parasite load goes down, 6 months of deworming, okay? The red bars represent after deworming. Whereas, in the same token, the immune activation also tend to go down, depending on the load of the parasite. So we ascribed these immune activation markers among the Ethiopian migrants, as well as those that we confirmed in our setup in Ethiopia, that after treatment of the helminthic infections, the immune activation markers go down. So we ascribe that this predominant chronic immune activation with chronic immune suppression, hyporesponsiveness, is related to chronic helminthic or intestinal parasite infection. Actually, we wrote a review recently on Frontiers in Immunology, suggesting that this chronic immune activation, helminth-induced hyporesponsiveness, may result in reduced COVID vaccine efficacy in our setup. But in the same token, it might reduce also the pathogenesis of severe COVID-19. So it is a kind of a double-edged sword, okay? And this is a very nice review done many years back, 10 years back, by a group in the UK, and in the UK, showing that helminths impact on bystander responses to heterologous infectious diseases or antigens or vaccines. For example, in the upper panel, it could be detrimental to vaccines or to pathogens, whereby the control of the pathogen is dependent upon Th1 immune response, such as leishmania or other protozoal or bacterial infectious diseases, as well as to vaccines, including tumors. On the other hand, it could be beneficial in diseases related to, whereby the pathogenesis is related to chronic inflammation, such as asthma, autoimmunity, or inflammatory bowel disease. So this is a double-edged sword effect of co-infection with parasites. So given our experience on the chronic immune activation in our setup in Israel that we have been investigating for the last 2 decades, then when the COVID-19 come into picture, we try to observe this phenomena in the current study. Just to brief you briefly on the pathogenesis of COVID-19, after infection of the lung cells, this leads to pyroptosis, or death of the infected lung cells, okay? In the majority of the population, this leads to mild or moderate disease, such as clinical presentation with fever, cough, and so on, and resolves in those with potent immune response. But in few at high-risk patients, this results in what is known as dysfunctional immune response, characterized by hyperactive immune response, production of pro-inflammatory as well as inflammatory cytokines that lead to a phenomena what we call cytokine storm. And this cytokine storm results in multi-organ failure, renal failure, including cardiac failure, shock, septic shock, and eventually death. So it is the cytokine storm, that is the hyper inflammatory condition that kills the patient rather than the virus. And this has been associated with mortality and severity of COVID-19. So given that helminths induced H2 immune response, several hypotheses were forwarded. The first, while we were starting, we were writing our proposal to the European Union, this comment was forwarded and published in Nature Reviews from a group from Australia, suggesting that actually helminths can enhance COVID-19 severity in endemic regions. But then we wrote a comment to Lancet Infectious Diseases suggesting that actually the reverse could be true based on our experience. And we suggested that chronic immune activation associated and induced by helminths may mute COVID-19 severity in African setting. But Lancet rejected this paper. They didn't accept our opinion. Few weeks later, a similar opinion appeared on PLOS NTD, suggesting that actually helminthic co-infection reduces severity of COVID-19 in co-infected population. They suggested it attenuates severity, which was similar to our hypothesis. Later on, several publications came into picture. And also we published another paper. Not only the parasites, but the microbiomes could be also involved in this pathogenesis, which right now we are trying to investigate. I was interested to hear the previous lecture on strongyloids and microbiome interaction, similar to that one. So what we suggested was actually, given the fact that parasites are not only one, it's not like one leg, 1 foot fits all kinds of shoes. It differs. We have different types of parasites. We have protozoas. We have helminths. Some of the parasites are tissue parasites. Some are blood parasites. Some migrate through the lung. Some, they have different species. So we think that the parasite species specific immune responses are responsible, and the different stages of the parasites may ensue different kind of immune response. For example, those parasites that bring about diverse microbiota balance within the lumen, with Th2 immune response would result in minor COVID-19. On the other hand, dysbiosis by highly pathogenic parasites like invasive E. histolytica or extra-intestinal Entamoeba histolytica or disseminated strongyloids, or maybe blood protozoa such as malaria, severe malaria in particular, or toxoplasmosis with Th1 immune response may aggravate. So, it could be a double-edged sword that needs investigation. So with this background, this was our aim, to just ascertain whether pre-existing skewed T helper type 2 and T regulator immune profile with a background of helminths residing in sub-Saharan Africa indeed actually attenuate COVID-19 severity in our setup. So we embarked on this project which has several objectives, but one of the secondary outcomes is the subject of our today, to investigate the proportion of severe COVID-19 patients with or without parasites, including investigate the different species. Our study design was a prospective observational cohort study, as I mentioned, as part of the Profile COV project, whereby we screened patients or healthcare workers for COVID-19, okay? And healthcare workers screened or patients confirmed, or those who are asymptomatic and positive, confirmed by RT-PCR for SARS-CoV-2 infection, were enrolled, and they were prospectively followed during isolation or during hospitalization at ICU. So we have done several immunological investigations on these patients, including we have collected biobanked plasma and cells from these patients, including stool exam we did immediately, but also we stored it for further microbiome studies. And then we determined at the end of hospitalization the outcome of the COVID-19 severity. In general, for this project, we enrolled 881 patients, 130 patients were excluded for various reasons. 751 patients sufficed based on our calculation of the sample size for this project, and 467 were without parasite, of which 228 developed severe COVID-19 at the end of hospitalization, whereas 284 patients were positive for parasites, and at the end of the day, only 27 developed severe COVID-19. The findings, in general, as I mentioned, you see the age group of our cohort is very low compared to the West, less than 40 years, okay? If you see those above 60 years, it's very low, okay? This is very remarkable that we notice it. The other feature is that patients without parasites had more clinical findings compared to those without parasites. This was statistically significant in terms of fever, dyspnea, cough, whatsoever clinical presentation they have. More interestingly, patients without parasites had a lot of comorbidity, which is highly statistically significant, including comorbidities which are non-communicable diseases, like diabetes, hypertension, cardiovascular disease, and so on, okay, including HIV, which was actually not statistically significant in our case because of the small number of patients co-infected with HIV in our cohort. Anyway, when you see into the outcomes, we had more severe cases on those without parasites that required admission significantly to the intensive care unit, required supplemental oxygen, as well as invasive mechanical ventilation, also higher mortality in those without parasites compared in those patients without parasites. And this is the parasite distribution among our COVID-19 patients. As I mentioned, among the 751 patients enrolled in our cohort, almost 38% harbored either one or more parasites. 20% were protozoa, 25% were helminths, 9% were polyparasites. Polyparasitism is also common, showing that a person is infected with more than one parasite. Entamoeba was the commonest protozoa, whereas Hymenolopis was the commonest helminths among our co-infected patients. More interestingly, with increasing severity from asymptomatic to critical, if you go from asymptomatic to more severe form that is critical, the prevalence of the parasites was reduced, which is clearly seen in this panel. Okay, see, very interestingly, whether it is a parasite, a protozoa, or helminths, okay, it goes down progressively with increasing severity. And this is clinically significant, okay? The association was clinically significant, not only at parasite class level, but also at species level. Look, these figures from asymptomatic cases going to mild, moderate, severe, and more critical cases. Look the trends. The proportion of parasitism was going down, and you could see the p-values for most of the species as well as for the classes was statistically significant. What about the factors associated with COVID-19 severity in our cohort?
Sorry for the interrupt of the internet. Maybe the internet was interrupt or something. Professor David, are you here with us? I think maybe the internet of the professor was interrupt. So we waiting for the professor to join in the Zoom again. During this time, if the participants have the questions, you can put in the chat box while we're waiting for a professor. Professor, can you hear me? Professor.
Sorry, for some reason I was interrupted.
Thank you. Now we can hear you very well. Please
Okay,
continue.
Okay, so you know when we try to do logistic regression analysis in terms of severity, as I mentioned it earlier, age, urban residence, and also comorbidities were significantly associated with COVID-19 severity. Okay, very interestingly, as you could see in the lower part of the slides, having any parasite, protozoa, helminths, or polyparasitism was significantly associated with lower risk, okay? So this was kind of interesting for us. And also we determined this at species level. At species level, as I mentioned it, gender, age above 60, urban residence, obesity, comorbidities were all associated with increased risk of COVID-19 severity. But interamoeba species, okay, Hymenolopis, schistosomiasis, Schistosoma mansoni, Trichuris trichuria, were all associated with reduced severity of COVID-19 in our cohort. This was kind of very exciting and interesting for us, again, proving the hypothesis that such co-infection results in reducing COVID-19 severity in co-infected patients in Ethiopia. Another interesting study was that not only that parasites were associated with reduced severity, but also parasites having parasite, and this is multivariable logistic regression model adjusting for gender, age, and also other cofactors, showing that having parasites is associated with lower risk of non-communicable disease. Very interesting, including at species level, okay? While we submitted our publication, our paper for publication to eClinical Medicine, few papers are also coming into picture, strengthening our viewpoint. A paper from Egypt, for example, has shown that higher proportion of co-infection with protozoa, okay? Different protozoa, including Toxoplasma, Cryptosporidium, Plastomycosis, and others, Giardia, were highly prevalent among mild compared to severe, exactly like our story, okay? But unfortunately, the authors in this paper, they didn't do multivariate regression analysis, and they didn't calculate, what is the odds ratio or the risk of developing severe disease or mild disease, whether you have parasite and others. Also, another preprint, which is not peer-reviewed, showed that malaria is associated with death or with severity, but current malaria, this is past malaria, okay? Current malaria has no impact at all. Again, this was confirmed in a paper, the so-called ACOS study that has been published on Lancet recently, involving many countries in Africa, that malaria has no impact on mortality. Okay, you could see odds ratio around 1, not significant. A very interesting study actually from India shows that patients infected with malaria show faster clearance of SARS-CoV-2 infection compared to those without malaria. Very interesting. Co-infected patients with malaria indeed cleared their virus within a median of 7 days, which is 4 days earlier than those which are uninfected. Okay. In terms of, there is also another preprint on MedRx IV from Brazil showing that Chagas disease due to Trypanosoma cruzi have no effect on severity or mortality. So I guess after these publications and also our publications, several papers are going to come into the picture. So what will be the implication? As I mentioned earlier, the implication is twofold. Parasite-induced immune modulation may attenuate COVID-19 severity in endemic areas, as we have proven. But on the same token, what will be the effect on vaccine? As you are already aware, in Africa, we are only now 1% of the whole population is vaccinated by COVAX. So still, we have to investigate also, in South Africa, for example, for the they show a very low vaccine efficacy, as low as 60%. Is this due to co-infection, or is this due to the advent of the variants? We don't really know. So we need to investigate this in the setting of the sub-Saharan Africa, as well as in parasite, because our previous research published shows that efficacy to BCG, as I have tried to show you also on the paper we reviewed. For example, in Ethiopia, we have shown 15 years ago that efficacy to BCG is lower in co-infected individuals. When you deworm them, efficacy to BCG enhances. So we don't know whether the efficacy to SARS-CoV-2 vaccine will be also affected with co-infection. So we need to have this background while the vaccination program is going on. And another thing very interesting is we need to understand also the interaction between parasite, microbiome, and also SARS-CoV-2. So in summary, our study has shown for the first time that co-infection with parasites is associated with lower likelihood of developing severe COVID-19 in African patients. The association has been maintained after adjusting for confounding factors like, sex, age, also presence of comorbid functions. These are confounding factors that are mainly associated with COVID-19 severity. And also more evidence is required to corroborate our findings, including, as I mentioned, studies with microbiome. Finally, I thank you. I thank the organizers for inviting me for this interesting conference, and I thank our funders, EDCTP, as well as UPLANG Institute, and also all our collaborators from the different institutions. And I would be happy to address if you have some questions. I hope I have finished on time.
Interesting, informative, and very up-to-date in this pandemic situation. So now we are in the Q&A sessions. Are there any questions from the floor? Please feel free to ask directly to Professor, or you can leave the question in the chat box. Now we have the question in the chat box. Congratulations, very impressive talk. As you mentioned about the effect of parasite can decrease the effectiveness of COVID-19 vaccine while also reduce the severity of the COVID-19. In your opinion, is it the result from the same underlying mechanism? Are there any possibility to use the parasite antigen as the drug for COVID-19 treatment by do not reducing the efficacy of the vaccine?
Yeah, very nice question forwarded. Yes, as I mentioned, and also on the review that I showed from Meisel's group from the Liverpool School of Tropical Medicine that was on clinical reviews microbiology 10 years ago. The effect of parasite co-infection is a double-edged sword, okay? On the one side, it can protect us from Th1 immune response, but also at the same time, it can damage us if the protection requires Th1 immune response. Okay, the Th2 skewed immune response by tilting the effect to the Th1 immune response could be advantageous or dangerous. So in terms on those who are infected, it can protect against severe COVID-19. But on those who are getting COVID-19 vaccine for prevention, it may reduce the efficacy. So it is the same similar mechanism, but double-edged sword. The second question is kind of interesting. Now, as you are aware, there are several clinical trials related to the concept of what we call helminths therapy, okay? Helminths themselves or products of helminths like secretory products of helminths are being used for treatment as drugs. But I don't think it's going to be important for COVID-19 because COVID-19 is an acute condition that requires immediate treatment. Cytokine storm due to COVID-19 needs acute treatment, whereas the current clinical trials are for chronic immune conditions like, multiple sclerosis, diabetes, because our experience is that even if you deworm a person today, you cannot see reduced immune activation in 1 week, 2 weeks time. It requires months. It requires years sometimes. In the Israeli cohorts that we observed with Professor Bentuich, studies we did in Israel was that the Ethiopian migrants, when they go to Israel, it took them more than 6 months to be relieved from immune activation. And the same happened in our cohort in Ethiopia. But this will help us to understand, perhaps one German group is trying to understand this mechanism. And they are trying to block, based on this pathogenesis, trying to block the some of the ligands of related to innate mechanism, like the PD-1 receptor and so on.
Thank you very much.